In the last decade, we have seen breakthrough progress in our ability to prevent, diagnose, and treat cancer. But today, too many people living with cancer face barriers to timely and equitable care based on their age, ethnicity, or where they happen to live. At Pfizer, we're focused on addressing barriers and bridging gaps in care for all people living with cancer, especially those over age 65, who make up the majority of people living with the disease, and racial and ethnic minority groups who have a higher risk for cancer development and often experience worse outcomes. Based on research, we know these patients groups are not receiving optimal cancer care. But why is that? Today, my colleagues and I will discuss some of the most significant disparities we're seeing in cancer care, including the marginalization of older people and the lack of diversity in clinical trials. And we'll talk about some of the things that Pfizer is doing to help address these issues. As a society, we are living longer, healthier, and more active lives. In 2019, 24% of men and 16% of women aged 65 years or older in the United States were employed. And according to the AARP analysis, 32% of them volunteered on a weekly basis. This tells us that our country's older population isn't just surviving, they're actually thriving. So why are our mothers, fathers, aunts, uncles, and friends over the age of 65 not receiving the best care we can offer, particularly when it comes to cancer? We all want to assert that age is just a number. But when it comes to receiving optimal care, we are all too often beholden to that number. Age is the greatest risk factor for developing cancer, with approximately 54% of cancers occurring in people over the age of 65. And yet, research shows that older people living with cancer may not be getting optimal care, putting them at a greater risk of dying from the disease. We often see different treatment decisions by age across multiple cancer types, including colon, prostate, breast, lung, and some other blood cancers. In fact, one study of older patients with stage 3 non-small cell lung cancer revealed that 62% of patients aged 80 years and older received no cancer-directed care. Sadly, this was associated with a lower overall survival compared to those receiving treatment. And while tools to support these important decisions are available, such as a geriatric assessment, they are not routinely used or applied by healthcare professionals. At Pfizer, we are working with the cancer community to tackle these issues and identify solutions. Together with the Association of Community Cancer Centers, we are creating a self-assessment tool for doctors to identify areas for improvement in the care of older adults. But perhaps most importantly, we are driving efforts to address the lack of participation among older adults, as well as racial and ethnic minorities in clinical trials, a major barrier to achieving health equity.
We're talking a lot about diversity in clinical trials, and the question comes up, why is that important? And I think we just have to reflect on a couple points. First, cancer affects all ages and racial backgrounds, and treatment and outcome equity is not possible if we don't understand the safety and efficacy for diverse patients that reflect the actual population affected by the disease being studied. And we recognize that older adults and people of color are significantly affected by cancer, and in fact, we recognize that they are very underrepresented in cancer clinical trials. We also recognize that older adults continue to be underrepresented despite the fact that most cancer occurrences are in the older decades of life. As a result of that, diagnostic and management strategies are commonly developed using data from younger patients, challenging the delivery of informed cancer care in older adults. There are many factors that contribute to a lack of clinical trial participation among older adults, and Pfizer recently outlined in a publication for the Journal of the National Cancer Institute some of those points. And if we just go through them really quickly, they include trial eligibility and design. So we have to assume that at the outset, we shouldn't exclude older patients from trial design and avoid sort of de facto assumptions that people who are older shouldn't participate. Then we also have to include assessments and endpoints that matter to these patients so that they're encouraged and interested in participation. And we must involve patients and oncologists in the design and then come full circle and fully report data back to the participants, of course. At Pfizer, we're committed to advancing solutions in these areas. For example, we recently established a Diversity in Clinical Trials Center of Excellence, and the purpose of that was helping to promote diversity from the earliest stages of study design. Pfizer has also designed technology platforms that provide real-time patient recruitment and retention data, and then early signals on where we should deploy our recruitment tactics to address challenges.
It is well established that cancer disproportionately affects racial and ethnic minority groups, and this is reflected in a higher risk of developing cancer, in presenting with more advanced stages of the disease, and ultimately with a worse prognosis and outcomes. However, despite this, ethnic minority patients continue to be underrepresented in clinical trials for cancer. While this lack of representation is being recognized by cancer groups, many barriers to participation still exist. And my colleagues and I recently discussed these barriers as well as potential solutions to tackle them in a publication in the journal Cancer. These barriers include a distrust of healthcare and medical researchers due to historic past abuses, low levels of awareness of clinical trials, limited access to optimal healthcare and treatment, inadequate health insurance, language barriers, and logistical burdens. Closing the gap in clinical trial participation will require a fundamental change in how we conduct clinical trials, how we train clinical trial staff, as well as how we engage the community. To that end, Pfizer is collaborating and working with the American Cancer Society, where we have established a number of grant programs that are focused on reducing racial disparities and optimizing outcomes for Black patients by addressing systematic race-related barriers that we know impact outcomes across cancer types. We also, in order to address feelings of fear and mistrust, have established the Blue Button program, where Pfizer gives back to clinical trial participants their individualized electronic health data so that they can understand how their data became part of a larger clinical program. We hope that by behaving in such a transparent manner, we can foster trust and increase participation in clinical research. We are also involved in a cross-industry initiative called the Center for Information and Study on Clinical Research Participation, where we share best practices and co-create actionable solutions so that those initiatives that work become industry standards. We have made progress through these programs, but a multi-level approach is needed to move the needle and significantly improve clinical trial participation for racial and ethnic minority groups. The biopharma industry can be pivotal in driving this change, and we are committed to do so.
Pfizer is committed to addressing inequities in care to ensure that all people living with cancer, no matter who they are or where they live, can benefit from advances in science. Achieving health equity should be a national and global imperative, and everyone has a role to play.